Hello, and welcome to my course, From Evidence to Execution, Elevating Cardiac Resuscitation Education for Athletic Trainers. My name is Grace Savage, and thank you for being here today. Before we get started, just a note, this presentation is designed to encourage critical analysis and support evidence-informed decision-making. It provides general educational guidance and should not be interpreted as a replacement for established EMS protocols, institutional policies, or licensed medical direction. Practitioners are expected to exercise clinical judgment in accordance with their scope of practice and local regulations. What we're going to talk about today, we're really going to try to understand the current gaps in our standard curriculum for athletic trainers when it comes to CPR and cardiac resuscitation. And when I say curriculum, I'm mostly referring to our post-professional curriculum, whether that's our recertifications or continuing education type of things that we need to kind of dive into that I feel like that we're not. But it can also translate into our KE level curriculum. They tend to be a little bit better at it, but there are still some gaps I think that this can translate there as well. But we're going to go through the types and signs of cardiac arrest and common barriers to recognition, and really go through the physiological mechanisms of resuscitation, compressions, ventilations, defibrillations, how those all kind of tie together and how you need to know those things to make clinical judgments and why they're so important in our curriculum. We're going to talk about understanding the importance of establishing and maintaining airway and oxygen skill sets. We're going to talk about cardiac EAP practice and how that needs to be integrated into our workspaces. And then I really just want to be able to differentiate between like the minimal recertification requirements that we have and really what's evidence-based best practices for actually maintaining competency in these skills for healthcare providers. And then be able to kind of take that and back to wherever your setting is and evaluate your current trainings and see if there's a way that you can improve that to make sure that we are practicing at the top of our license. Just a short introduction. I've been a certified athletic trainer since 2012. I've taught CPR and minimally interrupted techniques for athletic trainers since 2017. I've spoken on that particular topic and at SWATA at our regional meeting, and I have some webinars out there on some more specific techniques. And I'm currently a sports medicine outreach manager at Children's Health Andrews Institute in Plano. All right, so the problem is that CPR is what we call a high acuity, low occurrence skill. So it's a skill that requires a lot of detail and doing very specific skill set, but it doesn't happen very often. And so that leads to what we call decay or skill decay. And that's been shown to present itself as early as 3 months after training. So it really just, if you don't use it, you lose it, right? And as athletic trainers, even more so, we really don't see this in any sort of regularity in our settings, but we are expected to be able to respond appropriately as healthcare providers. But our current curriculum doesn't really teach the entire scope of knowledge and skills that are appropriate for our scope of practice as a healthcare provider. And so there becomes this little bit of disconnect over what we kind of should know and how we should know how to respond and what we're actually being taught. And then on top of that, our certification has kind of just become a box to be checked. Every 2 years we go and we do it, and we kind of don't give it the intentionality that it deserves, and then we don't have really any framework for maintaining that competency between certifications. And so I'm proposing this kind of multifaceted approach that includes targeted education to increase knowledge and understanding of cardiac arrest and resuscitation science. So just making sure that we build a good foundation so that when we're talking about clinical judgments and we're talking about the decisions and the algorithms and everything as we move forward, even in talking about the skills, to be able to really understand why doing those correctly and doing them in a certain way is important. We really have to kind of understand what's going on during cardiac arrest and cardiac resuscitation. So just being a little bit more comprehensive in that area. Targeted education in airways and oxygen delivery. This is something you may, depending on when you went to school, you may or may not have gotten that in your KD program, but maybe you've never seen it since, never used it since, never seen it in the wild. And it just is a skill set that we really need to have and we need to be competent in. So being intentional with that type of education. And emphasizing having and practicing high quality specific emergency action plans, right? We know how important it is to have emergency action plans, but we need to make sure that they are comprehensive through cardiac response and just some specific things that need to be involved in that. And then having resuscitation quality improvement type initiatives, and we'll kind of get into what that is, specific to our setting and resources. So how can we make sure in our contexts that we are maintaining competency in the skill, and what are some initiatives that we can do with that? So I have these 4 steps to success that I think will get us there. We have master the why, sharpen the how, connect the dots, and practice, practice, practice. So let's get right into it. Step 1 is mastering the why. There's things that I really believe that every athletic trainer should know about cardiac arrest and about cardiac resuscitation, but it's really not taught in kind of our standard baseline curriculum. And first and foremost, that is that there are 2 types of cardiac arrest, and we'll get into that. But there's 3 phases that the heart goes through while in arrest and how that relates to our resuscitation efforts. A phenomenon known as pericardial restraint and how that relates to our resuscitation efforts. Really getting into the types of ventilation, we actually do have different types and different options to that, and what are those, and how do they relate, and when do they apply, and things of that nature. And then considerations for continuous compressions and being able to kind of understand when that's indicated and when it's not. All right, so the first and honestly possibly most important thing that I feel like is not really communicated very well is that there are 2 types of cardiac arrest. So we have our primary cardiac arrest, which in the athletic training literature is generally called sudden cardiac arrest, and that's arrest due to something wrong with the heart. The heart was beating, it was fine, and then it was not fine. For some reason, that can be our HCM, that can be our electrical pathologies, that can be our coronary artery abnormalities, can be commotio cordis, those sorts of things. The heart was beating, something occurred, and then it's not beating. Okay, very sudden. In this case, the blood is fully oxygenated, but it's not flowing. So if you think about a car, it's full of gas, but the fuel injector is not working, so it's not going anywhere, and you're not getting what you need out of it. From secondary cardiac arrest, this is non-cardiac origin, sometimes called aphyxial arrest or hypoxic arrest. And this is generally due to respiratory failure, drowning, choking, drug overdose, those sorts of things. So the blood is flowing, but it's steadily becoming deoxygenated, and eventually the heart muscle fails due to lack of oxygen. This type of cardiac arrest has really, really poor outcomes. It's a much harder situation to survive because the car doesn't even have any gas, right? We have to introduce oxygen before we even get anywhere with that. So these are 2 pretty distinct pathologies that we need to be aware of and be understanding of how to recognize it, because they will lead you down to some different algorithms and different clinical decisions. Another phenomenon that we need to talk about is known as pericardial restraint, or sometimes known as pericardial restriction. And that's so when a heart goes into cardiac arrest, we have a lot of pressure in the arterial system and very little pressure in the venous system. And so when the heart stops perfusing properly, all that pressure kind of flows from the arterial system into the venous system, back to the heart, floods into the right side of the heart, and then kind of sits there, and it will stretch that side of the heart. So all of a sudden we have right side full, left side empty, and the heart's kind of stretched a little bit, and it kind of starts to strangle itself. If you shock a heart in this state, you're not going to get the perfusing rhythm that you want, and it's really going to affect your outcomes pretty strongly. So it's really important to have pre-shock compressions to even out the pressures in the heart and to reperfuse the heart muscle as well as we can to kind of prime it for a defibrillation. This is why immediate compressions are really important, and this is also will lead into your decision making if it's some sort of delayed arrival or you don't, they're down and we don't know how long they've been down, we don't know why they've been down and things of that nature. This is something that has to be considered as you make your decisions. Then we have our three phases of cardiac arrest. When this model originally came out in the early 2000s, it really kind of changed the game of how we related our resuscitation efforts to cardiac arrest. Instead of um, some other kind of scattered approaches that they have, they were really able to nail down that it really depends on time, and time is the most important factor when it comes to cardiac arrest. And that's since then it's been proven over and over in how we build our interventions and the outcomes that we're seeing with that. And based on this, it really is a foundational model of cardiac arrest. And so when a heart, for one reason or another, has that moment where it goes into cardiac arrest, we really have this range of 0 to 4 minutes where the heart is still um, really able to conduct electricity, just for some reason it's not doing it properly, right? Now, this can be affected if it's secondary cardiac arrest. This can be affected by age and comorbidities, but generally, particularly in our primary cardiac arrest, we have about a 4 minute range. Okay, so we have this time where the heart is just really, really susceptible to defibrillation. And this is why early defibrillation is so important, because the heart is really in a decent place to be able to receive that type of intervention. Now, if we start to get past that into our past 4 minutes, kind of up to 10 minutes, and this is without intervention. Sometimes interventions can stretch the electrical phase a little bit, but eventually, without intervention, you're going to get to the circulatory phase. And with that, the heart just kind of starts to lose its potential to conduct electricity like it needs to. The twitching slows down. And we get that pericardial restraint, and we get this kind of lack of proper circulation even to the heart. And in this phase, if you shock a heart, it's really just not going to accept that defibrillation like it needs to, and you're not going to get the outcomes that you want. So this is where it's really important to do high quality compressions for 2 minutes or 200 compressions, depending on your approach prior to defibrillation. This is really, really important when it comes to delayed arrival, as well as you'll see this a lot in the EMS literature because they tend to be delayed onto these scenes like that if there's been no intervention. And then once we get past 10 minutes, really the outcomes are just really, really bad. So even with all the great science and drugs and interventions in our wonderful first responders, we can get a pulse back past this point sometimes. But due to the global tissue ischemia, we have really, really bad neurological outcomes. You can have global tissue failure, global organ failure. And you can even see kind of that reoxygenation, reperfusion injury, like we see in crush injuries and things like that, when reintroducing oxygen to these tissues that have been damaged creates more damage and has kind of a cascade effect. So just overall, once you get past 10 minutes, it's really, really hard to get good outcomes. And so that's why early intervention is so important. All right, so once we've built this kind of physiological framework, we kind of understand a little bit about what's going on in the heart, then we really, when we're talking about ventilations, it's really important to go into our different options and that we actually have some different approaches to ventilation and what that means and where that applies. And so we have active or positive pressure ventilation, and that's the use of mouth-to-mouth or bag valve mask to force air into the lungs. So our natural breathing pattern is diaphragm contracts, opens up the thoracic cavity. We have lower pressure in the thoracic cavity, higher pressure externally, and if the air flows in. Diaphragm relaxes, compresses thoracic cavity, higher pressure inside, lower pressure outside, air goes out. Okay, that's our kind of our natural breathing rhythm. When we talk about positive pressure ventilation, that's when we are creating a abnormally high pressure gradient on the outside so that we can force air into the lungs. Okay, and you can do this with or without supplemental oxygen. We can use air, we can use our own breath, we can use things like that. Passive ventilation, or sometimes known as passive insufflation, is a use of high flow oxygen in a non-rebreather mask. And that just kind of bathes the airways in oxygen, but doesn't create a pressure gradient. So there's just allows kind of the natural pressure movement through compressions or through agonal breathing or just bathing the lungs in oxygen without actually creating a pressure gradient, which can be important when it comes to cardiac arrest. Because if we hyperventilate or whenever we create that kind of high pressure in the lungs with a positive pressure ventilation, it affects the ability to have venous return to the heart, which will therefore affect our cardiac output with our compressions, and which we're already getting less than optimal just with the nature of manual compressions versus how the heart actually beats. But then by increasing those thoracic pressures, we're limiting the amount of blood that's actually able to get back to the heart. And it's been shown that hyperventilation events actually lead to poor outcomes. And it's also been shown that a high percentage, like 80% of hyperventilation, happens during BLS by BLS trained providers. So it's really a problem. Ventilating properly has been shown to be kind of hard to actually get people to do during a resuscitation event. And when we're teaching, a lot of times we talk about, watch how much we do, we do touch on, don't over ventilate, air will go into lungs, gastric distension, they're going to throw up and aspirate, which is fair and valid and should be mentioned. But it's beyond that. It's actually, even if you do get all the air in the lungs, you can still create problems. You can damage the lungs, you can damage your ability to actually get the circulation that you want. And then even on top of that, when we're talking about active ventilations, even trained respirators have been shown to take too long to perform ventilations, to do the airway maneuvers, to get the seal, to blow. We're supposed to have this kind of 10-second range, and that's been shown that people really kind of struggle to actually stay in that range. So it's just something to consider and know that these are issues when it comes to active ventilation so that we can learn to prioritize it properly. We talk about passive ventilation. This is best used with an adjunct or supraglottic airway, something to hold the airway open so that we can just kind of bathe those airways with oxygen. And it's been shown to create a more consistent oxygen concentration in the lungs without disturbing venous return because there is no pressure gradient. Now, when you have a BVM, you're forcing oxygen into the lungs and you get this kind of wave. You have high oxygen, it comes down, and you get high oxygen, it comes down. Um, with passive insufflation, it maybe doesn't quite get as high, but it stays consistent across the board as long as that oxygen is flowing and the airway is open. So that's something to consider in your decision making of how are we prioritizing oxygenation, active ventilation versus passive ventilation. But it also, again, requires airways, it requires oxygen to be available. So when we're teaching ventilations, I think it's really important that we emphasize the consequences when we're teaching. I think that these things have weight, and there are some situations where they maybe should not be as high on the priority list, and we're going to talk about that. But I think making sure that the weight is there, like, yeah, it's not just with a BBM, or making sure that it's done right and taught and performed in a detailed manner, I think is really important to make sure that people understand how important it is that the skill is done right. And then understanding of when it's needed. We'll get into that when we talk about our algorithms, but when we're talking about primary cardiac arrest, the blood is full of oxygen. And so once you kind of understand the weight of the different types of ventilation, you can prioritize, is it worth it to stop my compressions to do ventilations? Is that a risk that I need to take right now? Is that high enough on the priority list? And then regular training and practice. Again, we talk about how important it is to do it right, but we need to make sure that we are able to do it right. We may understand the gravity of it, but if we never practice it, then we still have a high chance of doing it wrong in the situation. So this is where regular training and practice is important. And then just understanding that ventilation science is constantly evolving. It's a really hard thing to study in the wild, in real life. And they are working on it. And just knowing that that's kind of constantly evolving and to kind of keep up to date on that. They are working on maybe some feedback mechanisms for a BLS provider and things like that that'll kind of help people make sure that we're doing this properly. But just know that it's a work in progress. It's a work in progress for sure. All right, so once we kind of know our ventilation options and we kind of have that weight of understanding the consequences of that and being able to kind of weigh, is this something that we need to do or not? We talk about our compressions. And I think overall we do a pretty good job about talking about minimizing interruptions and understanding that we need to be compressing as much as possible in a high quality manner. Making sure that we teach about the ramp and understanding that our first several compressions are really not super effective because we have to build up the pressure. And so then we get this situation where we have our compressions on this kind of ramp during the time. And so there's only a certain part of it that's really effective. And then when we stop compressions, that pressure pretty much immediately goes away. And we give breath and we give breath. And so it's so important to understand the gravity of that and looking at it on a chart and like over a span of time, if you're taking too long to do ventilations, then all of a sudden your compressions take up this much time and your ventilations take up this much time, and that's a poor ratio that's going to lead to poor outcomes. Okay, so just making sure that concept is communicated because then we can lead to, well, when and what and why would we do continuous compressions, right? So we see that same ramp, but as long as your compressions remain high quality, that perfusion pressure stays pretty high. And so that leads you to the discussion about considering for continuous compressions in early primary cardiac arrest. But if you just drop that on someone, oh, hey, in sudden cardiac arrest, when you run on the field, you don't have to do breaths, just do compressions. People will look at you like you have three heads. And it's very uncomfortable for them because we have these sort of ingrained beliefs about CPR, and it's fair. It's again, a very important skill, a life-saving skill. And so we've had these things that we think that it should be. And if you just introduce something that's different, it can be uncomfortable. It can feel very uncomfortable. They can be unwilling to do it or kind of unable to really wrap their head around it. So this is why I think it's so important that we build this foundation of the types of cardiac arrest and what's going on in the body, what ventilations do and do well and don't do well. So that when we talk about in primary cardiac arrest and early primary cardiac arrest, that blood is full of oxygen. Let's use it. Let's not stop our compressions. The generally accepted time frame is through the first three shocks, which can be kind of a 6 to 8 minute time window of continuous compressions and get the AED on them and get them shocked, but just continuing those compressions. And because ventilations just become a little bit lower on the priority list, and all of a sudden we have to ask, is the juice worth the squeeze? Right? But you have to get them there if you're going to introduce this concept because it can be really uncomfortable for clinicians. All right, so once we've built our framework, then we go on to the next step, which is sharpening the how. And that's really just making sure that we teach our resuscitation skills in a comprehensive and detailed-oriented manner. There are just things that we can't let people get away with. There are things that we need to make sure that we emphasize when we're teaching. When it's time for certification, we'll get into what we need to do between certifications to keep those to fight the skill decay. But it's really important that in the first place that we're teaching it in a high quality, comprehensive, detail-oriented way. So we're going to kind of get into a few things that I think is important that we emphasize. First and foremost, we know this whole talk is completely pointless if we cannot actually recognize cardiac arrest, right? And that's the most common barrier to proper intervention is even being able to recognize cardiac arrest. So off the top, I tell people, particularly again in athletic training, a sudden unexplained collapse is cardiac arrest until it can prove otherwise. Like that's kind of should be the framework of that should be where you go and then you rule that out. That should be your first thought to kind of keep you from overlooking it in a scenario. Overall, I think we have a pretty good standard for teaching people how to recognize cardiac arrest. Are they unresponsive? Sternal rub, tap and shout, those sorts of things. Not breathing normally. Now, this is always a problem when it comes to recognition because Over 50% of cardiac arrest victims have agonal breathing, which is kind of an occasional gasping or snoring type breath. And that's actually a really good sign of a viable brainstem and of a responsive situation that if you can get high quality interventions during this time, you tend to have really good outcomes. But unfortunately, people who are agonal breathing tend to have poor outcomes because they don't receive interventions because people tend to think that it's normal breathing. So it's really important to understand that the kind of occasional gasp, or sometimes people say it sounds like snoring. This is actually a sign of cardiac arrest and it's not a normal breathing pattern. Their eyes may be open, they may be rolled back, their pupils may be blown, those sorts of things. Just understanding they're not always going to be laying there with their eyes closed. Myoclonic twitching, particularly in early cardiac arrest, we tend to see these kind of full body twitches, kind of seizure-like twitches that can happen. And it's important not to mistake those for a sign of life and to understand that it can be a sign of cardiac arrest. And then no definitive pulse. So there is debate out there, can even train people appropriately determine if there's a pulse in the field, is it worth it? I think a couple points of emphasis is to make sure that you're not taking a long time to check the pulse. You either feel it or you don't. And if you're not sure that you feel it, then you don't feel it, right? And that's why the word definitive is so important. Do you feel a definitive pulse? If it's not definitive, then you err on the side of they don't have a pulse. And then something that, again, we don't teach. If we haven't built the framework, then we can't teach this. And that's what type of arrest. ECC guidelines allow for healthcare providers to tailor responses based on the most likely cause of arrest. But then if we don't teach people about the cause of arrest, then we can't make this clinical judgment. So honestly, it's a pretty easy recognition. Did they drown? Did they choke? Do we suspect a drug overdose? Secondary cardiac arrest. Were they running and they were okay and then they were not okay? Were they with you 1 minute and not with you the next minute? Primary cardiac arrest. Okay, it's a pretty easy distinction that it's been shown that even untrained non-healthcare providers can make that determination. So for us as healthcare providers, that's a very easy, pretty distinct line that we can determine when we're trying to figure out what's going on. What type of arrest do I think that this is? And then that will affect your clinical decisions down the road. All right, and high quality compressions. I'm not going to spend a long time on this. These are the pillars of our CPR curriculum, and I think that overall we do a decent job of teaching this. That's our hands at the center of the chest. But do know that people do tend to still do CPR a little bit too high, so making sure that we're talking about the lower half of the sternum. Yes, we want to avoid the very, very end of the sternum, but we want to stay on the lower portion of it. I recently heard a hack where you put your hand in the armpit and bring it straight across, and that's about where your hand needs to be on the chest, which I think is a really interesting hack. Well, you can also palpate the end of the sternum and come a couple of finger widths above that. Anything like that, but just making sure that people have good hand placement. We have our depth that's at least 2 inches in adults and up to 2 inches in children. A good kind of framework that's starting to come out for children because it's such a wide range of sizes that you might see in someone who classifies as a child, is the depth to be 1/3 of the chest, which I think is an easier visual when you're dealing with various sizes of victims. Then we have our rate, 100 to 120 beats per minute. Every generation has their song that applies to them that sticks in their head for that. But it can also be as simple as row, 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 your boat, row, 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 your boat. Okay. Making sure that people understand, feel, and perform the right rate in practice so they can know what it is. Because they are going to be more likely to be too fast during an actual intervention because of adrenaline and oh my gosh, this is happening. So just making sure that people feel that. And then allowing full recoil, right? We know that we cannot squeeze an empty sponge. You have to let the heart refill. And that might be one of the most important details when it comes to compressions to make sure that we're getting. But overall, like I said, I think we do a pretty decent job of this. But what I don't think that we get into like we need to is the ergonomics of compressions. A lot of times it's like, okay, let's get down with the mannequin and they get down, they're all willy-nilly, they're not lined up well. And it really can create a problem because when we're talking about actually doing compressions in a realistic scenario, you're going to do it for probably a pretty long time. Depending on where you are, your EMS response times can be 7, 10 minutes and beyond. But we're here in class practicing CPR for 2 rounds, 3 rounds, 2 rounds, get the AED on, do another round, right? That's really not realistic enough to give the type of education that we need to be giving. So first and foremost, we need to teach good ergonomics. And that starts with distance from the victim. If they kneel down and they're really, really close to the victim, then that puts your wrists in hyperextension, which can be even more painful than your CPR already kind of is. And it really affects your ability to put force appropriately from your shoulders down through your hands. All right, but kind of same applies to if you're too far from the victim. The physics is still bad, trying to get the force down at an angle, and all of a sudden it's not coming straight through the chest like it needs to. And it's going to be really, really hard to get the depth that you want, and you're going to get really tired really fast. So I wish we had some sort of standard of like, 6 inches from the victim, but it really kind of depends on the size of the rescuer and the size of the victim and a lot of things like that. So it's a little bit of a feel thing and helping them understand just kind of where that sweet spot is and what that needs to feel like for them to be able to appropriately bring force down onto the chest. And then a good base. I see this probably the most as people go down next to the victim and their knees are touching. And it's like just even trying to kneel, much less doing compressions like that for any length of time, is kind of hard because your core is having to activate, your hips are trying to activate because you're just constantly kind of wobbling. It becomes a balance exercise. And if you're trying to give quality compressions for a length of time like that, it becomes very, very tiring. It becomes a lot harder for you to do that continuously at a high standard. So we want to make sure that we're telling them to have their knees at a shoulder width, maybe a little bit wider. If they're gonna err anywhere, they can err on the side of too far. That's still pretty stable. But you get far enough, and that's a lot of hip external rotation. It can be painful. It can be hard on the hips. It can affect your ability to hinge, which is the next thing to make sure that we have people doing, particularly our smaller rescuers or our females. We don't have the upper body strength to be able to generate the type of force down into the chest. So we need to make sure that we're hinging. We lock our arms out. We're not doing TV CPR. The force is coming down through our shoulders into our hands, but it's generating from movement at our hips and our core. And that type of ergonomics is important. Then once you get them right in their ergonomics, then it's really important to practice for a realistic length of time. Possibly one of my favorite parts of class is when I have people, they're doing the scene, they're working the scene, they do their rounds of CPR. The AED comes, they get it on, it shocks. Maybe they do another round right after that, and then they just start looking at me like, "Am am I, am I done? Am I still going?" And I'm just like, "Yep, you're still going." They need to be able to feel what it's like to actually give CPR for a realistic length of time. How that is, how hard that is, how their compressions break down, so that they can start to get that feedback. And that's why feedback mannequins are so important. Whether it's mechanical feedback from your mannequin or personal feedback from someone around or from an instructor. So important to actually performing and learning the skill properly. So unfortunately, just mannequins that click really are not good enough anymore. They don't really meet the standard of a medium or high fidelity mannequin that it takes to properly teach CPR compressions. You really need a mannequin that's going to measure a rate, depth, and recoil and give immediate feedback on that. Sometimes it's lights on the shoulder. There's some that have like a little external tablet that has the depth and recoil and rate on there with little lights so that you can see it as an instructor, or you can put it on the ground so that the student can see it. But having that type of feedback and being able to feel how their compressions break down over time when they get tired, and just knowing what they're prone to do. Do I tend to lean on the chest and lose my recoil? Do I tend to slow down? Do I tend to lose my depth? Whatever that case may be, let them feel that, give them cues, see if they can fix it. and go from there. But that sort of feedback is really important. And then also, it's really important to, especially as healthcare providers, to talk about giving each other feedback during a situation like this. High quality compressions are so important. And so if the quality is bad, then the rest of your interventions can really lose their effectiveness. So it's important that if you see someone giving compressions poorly, that you give them some feedback. And so we always talk about in practice, how do you give that feedback? Give it in a clear and direct way. And how do you accept that feedback? If someone says, we need a little bit more recoil or slow down a little bit, I think your rate is too fast. How do you accept that type of feedback and apply it to your compressions? This is no time to get in your feelings. This is no time to get in an argument. If someone gives you feedback, you need to be able to take it and apply it. And so these are concepts that I think are really important that we are teaching in a classroom setting because that type of feedback in an emergency setting is really, really important. And then also that teaches them self-awareness to know kind of where their limit is. Studies might say that 200 compressions after that quality declines, okay, but everyone's actual ceiling is going to be a little bit different. So let them get there, let them get to that ceiling. And what does that feel like when their compressions break down? Are they aware of what that is? Can they understand that? Can they recognize when they need a break, when they may need to switch? They know what that feels like when it gets to the point where they really feel like they can't fix it, right? We need to take them to this point and then help them work through it and actually build that kind of ability to make that decision. And when we're teaching ventilations, it's so important to be detail oriented. We already talked about this a little bit when we were talking about the physiologicals and the whys in that framework, but it's really important to be detail oriented when we're teaching this, particularly in our active ventilation techniques. We can't just let them squeeze willy-nilly both hands on a BVM or things like that. We have to make sure that we're talking about how many fingers are going on the BVM, how much we squeeze. I love this picture. This is about 500 milliliters of liquid, which is the average tidal volume of an average male inside of a 1500 milliliter BVM, which is an average BVM. Okay, so we understand that we don't need the full volume of that BVM. And so what does that look like? Seal, squeeze, and rate are the three things that I feel like people struggle with a BVM, which is most of the skill, right? So if we don't have a good seal and we need to be doing a BVM, we're trying to force air into the lungs and we're just forcing it across the face. So making sure we have a good EC type of technique where we're sealing the mask across the face, understanding that some people are not going to be able to do that one-handed. So all of a sudden, BVM becomes a two-person job because one person has to hold the seal and one person has to squeeze. And that becomes another problem or another decision that has to be made and be considered for during a response. Am I even going to be able to do this skill? Making sure that we're squeezing either with just a couple of fingers or that just till we get chest rise. We don't want chest expansion. We want just a little bit of chest rise. And then rate. If we're going continuously, that's one breath every 6 seconds. People tend to squeeze really, really fast. Again, they get really kind of worked up during a cardiac event, which is fair. It's a scary event. And it tends to squeeze on the bag a lot. Too much. One breath every 6 seconds for continuous. And if we're doing our two breaths, and that's our normal 1, 2, 3 squeeze, and 1, 2, 3 squeeze. And when we're just teaching it, it's important to emphasize both the pros and the cons and how we prioritize that. Again, I mentioned that before. We just need to have a comprehensive understanding of it so we can understand when these different techniques apply. And then airways. Yes, airways and oxygen are well within the scope of practice of an athletic trainer and really should be included in our cardiac resuscitation skill sets. Some of us learned it in school and never once saw it or used it again in the wild, and so we've just completely lost it. Some of us have been around long enough that we didn't learn it in school, and so it's a pretty foreign concept for us. And that's okay, and that's understandable, but it's not acceptable to stay there. This is a skill that we are really expected to be able to do, and we need to be able to do it, and we need to have it in our tool set. Having oxygen available and knowing how to use it Having a tank is great. If you don't know how to use it, then that's useless, right? But having that around and knowing how to use it can really change your algorithms significantly and really just add a much higher level of care that you may be able to give. And this is especially important in a setting where you're going to have multiple healthcare providers available to work as a team. Because yes, compressions are most important. If it's just you by yourself, you're not going to be able to give compressions while you give oxygen. There are that plays into your algorithm based on who is going to be there and plays into your policies and things like that. But especially in a setting where you know that you're going to have a team around you to help you with this, this is where this really comes into play. And really, airways are nothing to be intimidated by. An OPA and an MPA are very straightforward skills. You can find instructional videos out there on the internet, step by step. OPAs are about $5 on Amazon. MPAs are about 10. Okay, not a cost barrier at all. Okay, we just have to know how to use them and know when they apply. Basic steps for an OPA is we measure from the corner of the mouth to the corner of the mandible. Okay, pick the size that fits that. If we need to open the mouth, that's a crisscross finger technique, pushing the mouth open. Insert the airway with the tip towards the palate, towards the top of the head. And as we insert, we rotate it 180 degrees, scoop that tongue out of the way, straight into the mouth. Okay. Um, it's as simple as that. OPA should be your go-to adjunct airway. MPAs are for if there's trauma or airway obstruction or something kind of in the mouth area that we don't feel comfortable trying to put an OPA in, or if they have an active gag reflex, then they can't tolerate an OPA. And so a nasopharyngeal airway is measured from the crease of the nose to the angle of the mandible. You pick the size that goes with that. It does require a little bit of lube so that it will go through the airways better. And then most people, their right nostril is a little bit bigger and is easier to insert. But you can make the decision as you look at them, and you insert it with the bevel facing towards the septum, and it should just slide pretty easily in there as well. Those are pretty straightforward skills, right? And there's really no excuse to not have these. If you need an airway mannequin to practice on, making friends with your local EMS can be really helpful with that because they have those type of resources. And then oxygen. Oxygen can be scary. Maybe the only thing we remember is don't drop it because it might explode, which we should definitely not drop it because it might explode. But it really is a really great tool that can be really helpful in cardiac resuscitation and other respiratory emergencies. Being able to have oxygen available and knowing how to use it is really a vital skill in the emergency care realm. So I have this diagram of a tank here. They're all usually pretty similar. Sometimes they require that black oxygen wrench that's there on the top. Sometimes they have a little doodad at the top that is a kind of a valve that's already built in. Regulators are sometimes on it. Sometimes you have to put them on and you just line up the pins. Nowadays they all come with washers and we don't have to worry about that. Tighten that T-handle down hand tight and your regulator is on. Attach whatever we're using, a non-rebreather, BVM, whatnot, and turn up the flow. When it comes to cardiac resuscitation, it's pretty straightforward because we always want high flow. Put that on 15 liters and let it go. Right? And high flow oxygen in a non-rebreather is considered a reasonable way to ventilate during early primary cardiac arrest. And you'll see that in a lot of your EMS. If they come there on a cardiac arrest, that's the first thing they do. They don't mess with an advanced airway. They don't mess with BVM or any of that. They will put a non-rebreather on, a lot of them. Again, you've seen one EMS protocol, you've seen one EMS protocol, but it's becoming pretty standard to put a non-rebreather, an OPA and a non-rebreather on for early cardiac arrest through the first 3 shocks. But you can also hook that oxygen up to your BVM, get 100% oxygen in that bag, and actively ventilate. And this is best indicated for our secondary cardiac arrest, right? Where they really, really need more oxygen and more immediately, and for our prolonged resuscitation efforts if it starts to get beyond that threshold, and we have to start determining whether we need to start forcing oxygen into the body. And then overall, just a note beyond the scope of this presentation, oxygen use for respiratory failure, sickle cell disease, and other emergencies really needs to be included in our educational approaches and in our continuing education curriculum, because this, again, can be really vital when it comes to immediate care of emergency situation. Teaching about different things like nasal cannulas and what those flows look like, and having a pulse ox so that you can determine, does this person actually need oxygen? Do I need to turn down the oxygen? Those sorts of decisions and those sorts of clinical judgments around the use of oxygen is something that every athletic trainer should be comfortable with. And then AED, again, not going to spend a long time on this. I think overall we do a good job of it. And it's been shown that untrained sixth graders can effectively use an AED. Okay, it's got pictures, it talks to you, those sorts of things. But there are a few things that I like to emphasize when I'm talking to people about the AED. And first and foremost, that is knowing your unit. If you have a Zoll and you've never opened it, and you're in an emergency situation and you pop it open and you see these Z pads, that might throw you for a loop. You're like, what? I thought I had to put one here and one here, and now what? And then all of a sudden you've got to look at the pictures closely and you've got to be, what am I supposed to do with this? And it becomes something that slows you down. So making sure that you know your unit. Know, is it going to shock them, or are you going to have to push the button? Is it fully automatic or is it semi-automatic? Knowing those sorts of things. Understanding our pre-shock compressions, even if it's witnessed, making sure that we're getting high quality compressions as we're getting that AED on is really important to perfuse the heart and to prevent pericardial restriction. But then also for an unwitnessed or some sort of delayed response, that person's been down for a while with no intervention, or we don't know how long they've been down. Making sure that we get a good 200 compressions or 2 minutes of high quality compressions on them before putting the AED, you can apply the AED, but don't shock them yet until you get a good round of those in any sort of delayed arrival. And then clear and direct communication. I just had 3 groups that we put through some CPR training, and 2 out of those 3 groups never verbally said anything when the AED cleared for analyzing and cleared for a shock. And that was pretty surprising to me, because that is something that's very, very important when you're utilizing an AED. So making sure it's not just clear into the void and hoping everybody's listening. It's looking around, who's working the scene. I'm clear, you're clear. It's trying to analyze. Everyone's clear. Don't touch the patient, right? And they're shocking. I'm clear, you're clear, everyone's clear. We're about to shock. No one's touching the patient. Communication goes even beyond that. I don't let them say, hey, you, go get an AED, and then get back down on the chest. They have to make eye contact with somebody, use their name if they know it. If they don't, then describe something about them, make eye contact, and make sure that they know that you are talking to them. And then tell them to go get the AED and where the AED is. Hey, you in the blue shirt, go get the AED. It's in the red bag behind the bench. It's on the wall at the end of the gym. Wherever the AED may be, tell them where it is, because even whether they may know where it is, and again, in the middle of an emergency situation, people tend to freeze, they tend to go blank, right? If you're going to elicit help, you have to be very clear and very direct with your communication. And then another thing that really has to be emphasized is immediately returning to the chest. So a lot of times it says shock delivered, continue CPR. And I'm like, once it says shock delivered, that shock is delivered. It's electricity, it's very instant. And so you don't have to wait until the R of CPR to get back on the chest. I'm like, I could have gotten probably 5 good compressions in this time that I waited for it to say continue CPR. And so I really, really emphasize that because when the heart gets reset with a shock, there's this point where it's kind of essentially trying to decide, am I gonna fall back into a non-perfusing rhythm, or did it work? Okay, and when it's in this state, it's important to not let it fill with blood again, not let it lose that perfusion, right? It really needs high quality compressions during this state so that hopefully it will return into a perfusing rhythm and your shock will have been successful. And then we really have to talk about drop to shock times. It applies when we talk about our EAPs as well. But because of that electrical phase, we have a kind of a smallish window of when it's best to put an AED on. So your drop to shock time, the standard is 3 minutes. So if you think that an AED that's kept on the other side of the other field or is kept inside when you're outside is going to be close enough, the likelihood is that it's not. And so understanding how important it is that you have it available to you within not just to bring it to you within 3 minutes, but it needs to be on the patient and shocking them within 3 minutes. And then just some special considerations. I just touch on these in a class. I think we don't spend a lot of time on them, but I think they're important just to expose people to. And first of all, that's in CPR-induced consciousness, which is a phenomenon that you see when you're doing compressions, doing good high quality compressions, and then that person starts to wake up. They might be groaning, they might be slapping at you, they might come all the way awake. There are cases of where people are GCS 15 and saying, hey, what's going on? When you're compressing, but then you're like, oh, sign of life, and you stop and they lose consciousness again and they crash. And you realize that it's your compressions that are generating this consciousness, not an effective heart rhythm. And so it's important to be able to recognize that and recognize that association with consciousness with your compressions and continue compressions during this way. It might be really weird. Like I said, it's been known to happen that they are actually talking to you. But if you stop compressions, then you're stopping perfusing their brain, and that's going to be a problem. So it's in just an important note, I feel like, to say that that might be possible. And then understanding if we are suspecting a heart attack, the person is conscious, they're having the signs of a heart attack, they really should be given 4-chewable aspirin immediately. And that should be something that is kept in your kit and kept in your meds. Because when we're dealing with a blockage in the heart, if they go into cardiac arrest, there's only so much we can do for them. They really need to immediately get to a high level facility to deal with that. And so having aspirin in the system like that can help slow down that blockage that's happening and buy you just a little bit of time to get them to where they need to go. So it's important to just touch on that. And then everyone's question they always have, and the answer is yes. Everything gets cut off during a cardiac emergency, even a bra, even a sports bra, everything's got to go. It gets in the way of compressions, it gets in the way of the AED. It just really has to come off. I understand that that can be uncomfortable. We understand that we want to preserve the dignity of our patient as much as we can. But in an emergency situation, there are just things that are higher priority than that. Now, if you want to build into your EAP that you're going to make sure people are clear back to a certain amount of distance, or that you have people surrounding you, or you have some sort of towel crew creating a shield, or whatever that may be, then great, do that. But understand that everything has to be cut off. All right, so once we've kind of built our framework and we've made sure that we have taught our skills in a comprehensive and detailed manner, we can't just leave them there with that. We have to talk about how do those integrate into real life? How do those integrate into EAPs? How do those integrate into policy and to treatment algorithms? How do those integrate into actually doing it when it needs to be done and doing it properly? So policies, first and foremost, a great cardiac policy does no one any good if it's in a binder on the shelf and no one actually knows it, no one's talked about it, no one's gone over it, and no one's held to it, right? Then it's just a piece of paper, right? So it's important that we have these policies, that your staff knows it, and that they understand that that is the standard, and they're expected to know how to do it and to know the skills associated with that. Your policy should include equipment it's expected on site, as well as a training regimen to uphold those skills. So if the standard is that you have an emergency bag and it's got your airways and BVMs and your oxygen and everything's maybe in a bag together, and the policy is that that bag goes out to every event or goes to X, Y, and Z, then that's what needs to happen, right? And it needs to be written down that that's the standard. When it comes, if I ask, if I came to you and I asked for a cardiac resuscitation policy and you hand me your EAP, that is not it. They are related and there's a lot of overlap, but an EAP is just an immediate emergency action plan, right? It's a one pager. This, if this happens, this is where we let people in. This is who's doing what, what's calling, boom, boom, boom. Should be kind of bullet point-ish, right? It's pretty concise like that. A policy expands on that, whether regarding the flow of decisions that can be before or after event, the communication, and maybe after event, and how do we debrief? Algorithms use expectations. The policy is the expectations of your staff of what they need to know. That can be as specific or as vague as you feel comfortable making it. But what is that? If something goes down, this is what we expect them to have on site. This is at least a basic decision tree that we expect them to work through, right? They have to have the flexibility of clinical judgment on scene, but there's a level of standard that needs to be set of what you're expected of your people on site. These should be reviewed, of course, with your team physician, with your medical oversight. That's a given. But also, you should review this with the EMS. They live off protocols like these, and they can really help you build to what's relevant to your training, to your equipment, to your setting, to what they're going to do when they come on site. They're great at building specific policies and yet policies that allow for clinical judgment on scene and those sorts of things. So they can be a really good resource when you're trying to build this in the way that it needs to be built. And this is just an example of kind of an algorithm decision tree based on the type of cardiac arrest. Because again, as healthcare providers, we're allowed to kind of change our algorithms based on the suspected cause of cardiac arrest. And this is just an example, but if we're talking about primary cardiac arrest, it's our sudden unexplained witness collapse. They're unresponsive, not breathing normally, no definitive pulse. We recognize that it's cardiac arrest. We initiate our AAP, we send someone to go get the AED. We do that, calling EMS. And then the first step should be to remove any equipment obstructing access to the chest. Football pads, hockey pads, lacrosse pads. Okay, compressions over pads have been shown to be non-effective. So it's worth a couple extra seconds to do your technique, cut the jersey, cut the pads, splay it up. You don't necessarily have to do the whole equipment removal shebang like we do for spinal injuries, not at that moment. You just need to open up and get access to the chest. So open it up. And for primary cardiac arrest, you can start continuous high quality compressions. And if you have enough people, somebody can be dedicated, and that can be in your policies and in your EAPs, to insert an OPA and start oxygen at that time. If you don't have enough people, just continue the compressions until the AD arrives and until EMS arrives. You can also tweak that to, we have somebody, this person went to go get the AD, we shocked them once, now that person, their healthcare provider, trained healthcare provider who brought the AD and the AD's on, and you've done a shock. Then now you have two people, but you only need one to compress. So maybe it's after the first shock and the other person starts with the airway and with the non-rebreather, right? These can be tailored to the number of people and the level of training that's going to be on site, right? But these are just decision trees that you need to kind of think through so that you're not having to think through it in the middle of an emergency. Work through it and know what's expected based on what you have and who you have there. Right, once the AED is ready, we've exposed the chest, put the AED on. If it's shocks advised, we shock them, and we immediately resume high quality compressions, right? We know that kind of that part of the algorithm is always the same. We immediately resume, and we don't stop unless the EMS tells us we can't continue, brusque happens, things of those nature. Compressions, a couple notes on these type of algorithms is that compressors really should switch every 200 compressions or 2 minutes of compressing. That's kind of the threshold. We mentioned this a little bit earlier of when we show that the quality of compressions tend to decline. If you have enough people, I worked at an institution where the policy was 100 compressions and switch because we felt that at any given time we were going to have enough trained people around to be able to have that kind of rhythm. Okay, but that's a decision that can be made, but just understanding that if at all possible, if you have enough trained people, it's important to build in what the expectation is for switching. And then talking it through with your medical oversight, talk it through with your EMS. When are we considering that I need to stop doing continuing compressions, and at what point do I need to start ventilating, and what does that look like? If I have a non-rebreather and an OPA in, is that okay until EMS arrives, or is there comes a point when you take that non-rebreather off and put a BBM on? That is a clinical decision and a clinical policy that needs to be made with your medical oversight and with EMS. And then an algorithm for secondary cardiac arrest. That's our drowning, choking, suspected overdose, or we kind of lump in with here our unknown or unwitnessed collapse. We don't know why they're down. Nobody saw it. We don't know what's going on. We don't know how long they've been down. It follows kind of a similar algorithm. Comes down, same thing. We recognize it's cardiac arrest. We initiate our EAP. If you have Narcan, which you should, it's free. You can get it from your state probably. There are organizations out there that give it out. Please, please carry Narcan. Retrieve it if you suspect any sort of drug overdose. We're removing equipment again, but when we begin CPR, this is going to be high quality compressions with rescue breaths. And again, depending on the number of people and depending on the equipment available, kind of depends on the decisions that you make from there. That could be continuous compressions with BVM ventilations at 10 breaths per minute, just until chest rise, and you can do that with or without oxygen. Or you can do your 30 compressions in 2 breaths, whether you're using a BVM pocket mask, or mouth to mouth. Again, based on what you have available there. But ventilations are a higher priority in a situation like this. We still expose the chest. We still put the AED on. With the caveat that if this is an unknown collapse or unwitnessed collapse, we need to make sure that we get 2 minutes of high quality CPR before we shock them. And then we're immediately back on the chest. We still have considerations for switching compressors. If it's indicated, if we think it's an airway obstruction, we follow our airway check protocols and looking at that and pulling it out. If we see it, we don't do blind finger sweeps anymore, right? But if we see that obstruction, we try to get it out. And then the rule for Narcan is as soon as it's available, give it. We don't wait for that at all. If you have it and you suspect a drug overdose, give it. And it's very important to do that as immediately as possible. But this is, again, just an example of some decision trees and some algorithms that you need to go over, and you need to know what the expectation is and what the standard is for your setting, so that you are able to make the appropriate decisions when a problem arises. Then emergency action plans, right? We could have a whole other discussion about this, but it's worth touching on in this setting for cardiac emergencies. We know we have to have a site-specific EAP. It cannot be vague. This is what we generally do in an emergency. It has to be specific to that site, to that access and egress, to those people, to where the location of equipment is, those sorts of things. It has to be specific to that site. It has to be available. The world's best EAP does no one any good if it's sitting in a drawer. Okay, it has to be available. I would say beyond just being posted and visible, this needs to be disseminated to your coaches, to your stakeholders, to people that are probably going to be involved in the use of an EAP when you activate it. Make sure that they know that they have seen it, and that then it must be practiced by everyone involved. Because again, they see it, they read it, they know it conceptually, maybe, maybe not. But once you do it, then it sticks better. Then you've seen it, done it, you've worked through the kinks, and you can maybe even have to tweak it a little bit as you understand that some things maybe don't work very well or some things need to be changed, but they have to be practiced. And then they really, really have to be part of orientation. I know we're in a labor crisis and we have people coming in and out of jobs at kind of random times of our season, but it's so vital to be like, here's your keys, here's where you find the gator, here's your water source, and here's your EAP. And we're going to kind of go through it. And I want you to make sure that you understand it. If you have time to actually go through a full practice of that, that would be great. But making sure that people understand it, understand the EAP as well as understanding the policy and what is expected of them at that time. That has to be communicated upon arrival because otherwise you're just doing them a disservice and you're kind of leaving them out to hang. All right. Emergency medical system consults, so important. Make friends with your EMS. Say it once, say it 100 times. They can be such a great resource for you. Consult with them on your protocols, as I mentioned before, and how can you complement them? If you're on site, this is what you're going to do. This is what can I do to be of assistance? What can I start before you even get on the field? Etc., etc. If you're not here, what can I get started? Oh, your initial policy is to non-rebreather over an OPA with oxygen. I have that. I can get that started. So then when you get here, you can jump to the next thing already and you don't have to worry about that. Okay? Whatever that looks like, but those are conversations that are really worth having. And then making sure that you practice your EAP with them because they have a gurney and they may have a mule or some cart or their ambulance, and we need to make sure we said the ambulance comes through this gate. Can it fit in this gate? Do they come up here? What do we do with these stairs? Is there an elevator? All the things, all the practicalities need to be worked out with them on site. And then if they are on site for an event, medical timeout is non-negotiable. I'm going to go ahead and say it. If you don't do it, you're just being negligent. You have to go over with them, with the crew that is there covering your event at that time. Let them know who you are, your training, and then what are you going to do here? Are we putting them on a board? Or are we putting them on the gurney? Um, from a cardiac arrest standpoint, what are we doing if I start compressions? Do you want me to keep doing them? What are you bringing? What blah blah, etc. Talk through it. Where are we transporting? Where's the highest level, nearest high level facility? Are we putting someone on a helicopter? What's the plan? These are conversations that have to happen so that communication goes as smoothly as possible and handling the emergency goes as smoothly as possible because these things have been touched on. Then practice, practice, practice. I've already said it a couple times before, and I will say it a couple times again. It is vital to practice these resuscitation skills and our EAPs regularly to stay up to date and avoid skill decay. We just really, as a profession, don't do it often enough to keep our skills as sharp as they need to be. So we need to build training regimens and expectations for how often that we're going to practice this so that we can maintain our competency. The AHA has a initiative called RQI, or Resuscitation Quality Improvement, and that's this little cart that they have inside of healthcare facilities. It has the dummies and the BBM. There's a tablet that'll track who it is that's doing it and give you the feedback that you want. And they just roll it around, or people are required to come to them, depends on the policy and the situation, and they test people's skills. This can, depending on the facility, sometimes this is monthly, sometimes it's quarterly, but it's at least quarterly. And is this really going to be applicable to an athletic training setting? Probably not. That card is pretty expensive, but the concepts can apply. What can we do to have our own RQI that is relevant and applicable to our situation? Okay. And really, in the end, that's that this skill should be practiced at least quarterly. So it does not necessarily have to be a whole EAP rehearsal. It doesn't have to be a whole EAP practice. I'm talking about the nuts and bolts of your resuscitation skills. So you can just pull out a mannequin and go through a scenario where you're doing your compressions, doing your breathing and your breaths with different approaches, doing an AED, and making sure that you understand those steps and that they are sharp in your mind. I understand that a lot of people go elsewhere for their certification because they don't have necessarily a mannequin on site, and that can be a barrier. But you can get pretty creative with that. If you work at an institution that teaches any sort of healthcare profession, somebody has a mannequin. Go make friends. Okay, you will probably be able to find what you need there. Again, I say it again, make friends with your EMS. If you have a relationship with your local first responders and you call them up and say, hey, can I come use your mannequin for like 20 minutes to practice my skills? I'm due for that. They are probably going to be okay with that. In my experience, they have been very responsive to things like that and to being helpful to us because we have built that type of relationship. But then in the end, it might be worth it to prioritize and just get one set of what you need. I'm not talking 6 mannequins so that you can host a big class. I'm talking one so that you and your staff can appropriately practice your skills and maintain the competency that you need. It might come to a point where that's just a priority that needs to be made. One more note on EAP practice. EAP plans, yes, we know they should be rehearsed annually, but that's per EAP. So the fact that you get everyone together in the summer and you're on the football field and you're practicing your football field EAP is great, but it's not quite what the AT that works in the gymnastic gym needs. It's not quite what you're going to need if you find yourself in the basketball gym or in the wrestling room or in the weight room, right? Those things, those locations each have their own challenges, which is why we make site-specific EAPs, but we need to practice all of them, which I know can be daunting. So again, you can get creative with this. What does that look like? Maybe our quarterly practice, each quarter, we practice those EAPs that are relevant to that upcoming sport season. Maybe you do that. Maybe you block off a whole day, a couple of days in the summer, and you just systematically work through it. Maybe it looks like that. Making sure that your practices include all medical personnel typically present. So if it's a football situation and you normally have 3 docs and an extra paramedic and the EMTs on site, then practice with those people. They need to know what the communication is. They need to know what the plan is. They need to know who's going to run the scene. All of the things. It's so important to actually have those people there. If you know that it's just going to be you and the coaches, then you and the coaches need to practice it. So it needs to be specific to the need. And then when you're thinking of your scenarios, think of them realistic yet worst case scenario and practice that. If it's, oh no, this person went down at my feet and I have my AD right behind me. That's just too easy, right? If that happens, that's great, and it's probably going to have some really great outcomes because it's just right there and it's very straightforward. But we know real life tends to be a lot more messy than that, and it's gonna do you a better service if you can actually practice something that is a little bit complex or complicated. So maybe they go down on the farthest end they might ever possibly be from you, or next to the band stuff, or but in the bleachers, or you know what kind of worst case scenario can you think of? And let's work through that. So then when anything that's not that happens, it just feels easier and you don't have to necessarily deal with all of that complexity. This type of practice will also help you if you're trying to advocate for resources. So if you can do this practice, document it when you train, who you train with, how it went, and you can show that, hey, if someone goes down over here, which is a worst case scenario, but it is a realistic possibility, it takes 5 minutes to run into this building or run to the other field, get the AED, come and put it on and shock them. And that's outside of the acceptable standard for a drop to shock time. All of a sudden, you have documentation of that, and you can take that to the powers that be and say, I was not joking when I said that I needed another AD, and this is why. It can be really helpful for you to help you advocate for the resources that you need. And it can also be really helpful for your insurance rates. If you take that to your institutional liability insurance folks, and you can say these are the risk reduction strategies that we're doing. This is equipment and the personnel that are on site. You can actually sometimes save your institution money. But overall, these 4 steps to success are really about intentionality and attention to detail. those two things will really bring the success that we want and raise the level of competency that we're looking for. And as leaders and educators, it's really important to emphasize these points and to make it as relevant to our audience as possible. Like, we might have a mixed bag of a class if we're doing mixed professions or something like that, and you might have to jump from one to the other. But if you're here eye to eye with athletic trainers and you're teaching other athletic trainers, then make it as relevant to them as we possibly can, because that's what makes it stick and that's what makes it real. And let's talk about barriers and let's talk about those situations that we might actually come across, because we have such a unique profession. They're not going to have, the HA is not going to give you a framework for that. We know that, and we know the barriers and we know the things that we face. Let's talk it out so that when we are faced with it in real life, it's not the first time that we've at least worked through it on a mental level, right? And if at all possible, on a physical level. And as students, it's really important to give this training the attention it deserves, right? Even if it's our 15th recertification, we've done this over and over. Lock in, understand that this is a skill that you don't do very often, but when you're called to do it, it means someone's life is in the balance. Okay, there's a weight to that we really have to give it every time that we come to recertify. And then having the humility and the self-awareness to know your gaps in your understanding, to try to notice what you don't know. That felt somebody said continuous compressions and I don't understand, that makes me uncomfortable. I don't remember airways, maybe I did them in school. I don't know how to do that. That makes me uncomfortable. Okay, where can we find that? How can we fill that gaps? I'm trying to help you out here. We're trying to get as many resources out there as we can, but and there are things out there. Maybe you look at the next symposium. Is anyone doing an airway lab? Is anyone doing a talk about this? Is there someone I can reach out to and maybe we can meet at this? Maybe there's not something formal happening, but maybe there's somebody that can help me with this. Okay, reach out and use the community, use the internet, use resources that you have, and take the initiative to fill the gaps in your understanding so that you can operate as you're expected to do as a healthcare provider. I know that there are barriers to this. I appreciate that resources are thin in many, many cases, and that can be a real barrier to doing what you need to do, or having the equipment on site that we really need to have on site. Um, sometimes it's advocacy, sometimes we have to get creative, sometimes we make friends with our EMS and see what kind of exchanges we can do with them. But sometimes it's a priority thing. I've If you tell me you can't afford emergency equipment, but then you turn around and you buy 10 BFRs, do you really not have money for that, or did you not prioritize that? So sometimes it's a bit of a mindset issue. What is the priority right now? First priority should be to make sure that no one under our care dies if we can help it, right? We should preserve life, should be our highest priority. And we need to make sure that we have that framework first. And then we get into the fun stuff and the rehab and the nitty-gritty and all the stuff that makes our job as awesome as it is, right? But sometimes it's a mindset shift about what is priority first and going from there. And then we have our wariness for unfamiliar skills and techniques. That's always going to be something that pops up. People are just uncomfortable with it. They don't remember it from school. They weren't taught it in school. Again, this is why I think it's really important to teach it in a systematic way and start with our frameworks and build a good foundation. Because once you get to something that's new or unfamiliar, then you have a framework to build off. And we're clinicians, we're really good at connecting dots and saying A plus B equals C, and being able to see how things interrelate, particularly when it comes to the body. So I feel like if we teach in a manner that's kind of comprehensive and step by step, then when you get to something that's unfamiliar or something that's uncomfortable, then it just makes it easier to get there and to get them there and to add that sort of skill, because all of a sudden it feels a little bit less scary. And then there's just complacency. Some people just will not. We're busy. I know we're busy. We're busy. But again, this is something that is really, really important, and holding people to a standard of the skill sets and the knowledge that they should have will really make sure that we are out there practicing as healthcare providers. And so doing all that we can to combat that complacency in ourselves and in the people around us is really vital to making sure that we have quality emergency care plans. All right, so I'm going to land this plane. Our take-home points, ATs must be familiar with the why of cardiac arrest. We have to be able to shape our clinical judgment. And so we have to talk about these concepts and we have to teach them as part of our education in both the pre and post-professional situation. We are expected to hold and maintain a high level of competency in the skill sets expected of a healthcare professional. And so we have to teach them in a comprehensive and detailed manner and practice them so that we can maintain that competency and practice at the top of our license. We have to build policies and EAPs based on these knowledge and skills, and they have to be specific to our location, equipment, and personnel. Athletic training is such a wide and varied profession. I'm sorry, but I cannot give you a cookie cutter of what you need. You have to sit down and critically think through these things and build what is appropriate and applicable to your setting. And then we have to practice them. They must be practiced regularly and reviewed with your medical oversight and your local EMS. And in conclusion, athletic trainers must elevate the way that we teach and practice cardiac resuscitation by becoming more comprehensive and detail-oriented, increasing our frequency of practice, and overall just holding ourselves to a higher standard. These are our references. Please don't take my word for it. Please look up things. Please talk with your medical oversight and dive into this. And just thank you so much for sticking with me. Thank you for being here. If you have any questions, if you want to talk through anything, if you need my help with anything, if you want me to help train you in anything, please reach out. Please let me know. I am willing to do many things to help people feel more confident in these skills and really get them to a point where we can practice as we are expected to do so. Thank you so much, and have a great rest of your day.